Okay, Aibowan, Namaste, Vanakkam. Welcome to this joint Internews Accountability Lab Nepal webinar on COVID-19 vaccines, access and accountability, supported by the Sabin Vaccine Institute. I'm Sunny Krishnan, and I'm Project Manager and Pandemic Health Journalism Mentor with Internews. Now, while COVID knows no borders, the vaccines unfortunately do. On average, 78% of the population in high and middle income countries have received at least one dose of an approved vaccine as of January 2022. Now, in low income countries, it's a sad tale. Just 10% have received at least one dose, and that's quite terrible, actually. The World Health Organization Director General has criticized blanket COVID-19 booster programs currently being carried out because of the Omicron variant. And he said that no country in the wealthy industrial nation can boost its way out of the pandemic, adding that such programs will only serve to prolong the pandemic as they rob poorer countries of the chance to immunize their populations. The longer the virus circulates in a context of what I say would be patchy immunity, the greater the chance of mutations that could render existing vaccines less effective or, God forbid, ineffective. Even though COVID is around to stay, thanks to its variants, equal access to the most effective COVID-19 vaccines is still critical. Vaccine equity would mean distributing these doses equally across all countries on a needs-first basis, regardless of the recipient's nationality or wealth. Health workers, other essential frontline workers, and those most vulnerable in every country must be prioritized. So what needs to change to reach vaccine equity, and most importantly, how journalists can report on these profound changes that need to happen? Joining us this evening, and I'm really humble, will be 5 prominent speakers, each a specialist in their own field, to help us answer these questions. Now, a few housekeeping rules before I pass the floor to my colleague, Dr. Jaya Shreedhar. Number 1, please mute all your mics if you're not speaking. This is an interactive meeting, webinar, so if you're not speaking, please mute your mic. And if you do have any technical questions, please put them in the chat box. If you have any questions, please put them in the chat box, questions or speakers to discussions, etc. If you do have technical issues, please message me directly, or you can message my colleague in Accountability Lab Nepal, Ashmita Sharma, and we'll try to help you navigate through this webinar. Now, on to you, Dr. Jaya Shreedhar, my colleague from Internews. Thank you.
And thank you, Sunny. And I'm Jaya Shreedhar, Senior Health Media Advisor at Internews. A small plug for Internews here. The goal of our public health work is to support journalists to engage and inform audiences, hold those in power to account, shape and change norms around public health, and also increasingly manage health misinformation. So welcome to this very exciting discussion. I'd like to once again thank the Sabin Institute for inspiration and support, and to our wonderful co-host, Accountability Lab in Nepal, and also colleagues at Internews. From our health team, Ida Ooster, Global Health Media Advisor, Beatrice Spadaccini, and Catherine Cleary from the Internews Health Journalism Network, and our Director for Health Programs, Megan Miller, for helping pull this event together. We'll be dialoguing on how journalism on equitable access to vaccines can be more effective compared with last year. Vaccine equity is recognized as a public health imperative that could single-handedly change the face of the pandemic this year and possibly for years to come. So over the next hour and more, we'll hear from people who've devoted time and effort to promote greater transparency and accountability for equitable access to vaccines and therapeutics. Please join me in welcoming Leena Menghani, Global Intellectual Property Rights Advisor at the Access Campaign of the Médecins Sans Frontières, better known as Doctors Without Borders. Welcome Ranjit Devraj, South Asia Correspondent at SciDev. Dr. Anand Bhan, immediate past President of the International Association of Bioethicists. Our co-host Narayan Adhikari, Director of the Accountability Lab Nepal. And we are already joined by, I was going to say we'll soon be joined by, but it's around 4 a.m. for Dr. Botatsi, and she's very much here with us. We're so privileged to have you here with us, Dr. Maria Elena Botatsi, Associate Dean at the National School of Tropical Medicine at the Baylor College of Medicine, and co-inventor with Dr. Peter Hotez of the world's first patentless vaccine for COVID-19, the production of which I'm proud to say has already begun in my own country in India. So thank you all so much for taking the time to be with us today and for your outstanding work in the field of vaccine equity. We're joined also by discussants from diverse backgrounds, including the former chair of the National Commission for Women in India, Ms. Lalita Kumaramangalam, and seasoned journalists from backgrounds as diverse as science, law, politics, and global health, who've all been deeply engaged and courageously vocal about social justice for health in the media. And in the end, isn't that what this is all about? So we're so delighted to have you here. So today's event is a sort of a roughly a three-part kind of a dialogue on how journalists can better track accountability for access to vaccines. Maybe we can look at the global context first before moving on to some in-country challenges and opportunities, and then we can put our heads together for the way forward. So let me turn to you, Leena, for some global context. I mean, you've been holding some very powerful players to account for equitable access to COVID-19 vaccines and medicines, and for ARVs before that for years. Where would you say the problems lie?
Well, the problem lies in the system itself. And I'm going to get straight to the point. I'm a woman of color who's worked for Médecins Sans Frontières. Very few women of color have actually risen to a position in MSF where we can talk about race, gender, color, everything together in the context of access. And I'm just going to put one point out, that it should be very apparent to journalists that this is not just an issue of technology or science or medicine. This is an issue about discrimination and inequality. And you can see it very clearly. There are massive time lags between a decade's time lag between antiretrovirals being available in high-income countries and then, of course, being available in Africa and India and so on. And the infamous quote in the US Senate where they say that, Africans don't know how to see the time, so therefore they don't deserve antiretrovirals. So it's an issue that has sort of plagued us for some time. I worked on the breast cancer drug, trastuzumab, as part of the feminist movement. And I can tell you women across the world do not have access to cancer drugs, for example, for breast cancer. And you can see those very same drugs saving lives in high-income countries. So it is an issue of inequity. It's always been there in past epidemics and pandemics. And it is now, of course, in the forefront of people's mind in this pandemic. And the numbers have been quoted by Sonny, and I'm not going to go into that. The issue that I wanted to simply say is this, that, for the first time, what you saw that, suddenly people started to see it in a larger political spectrum. And you see a response from the Africa Union and the African CDC, who then go on to say that we want to produce all of these products, not just vaccines, but they are very keen to produce other products as well. And we are going to set up a scientific hub for the mRNA vaccine and so on. Now, in the larger context, the countries and low and middle income countries that did not listen to advice, I would say, and actually took their own way. So what you see is the tools of manufacturing, the technology of manufacturing has been held by high income countries and the companies or corporations that exist. And that includes your Pfizer's and Roche for biosimilars, biological medicines. And you see that the countries that fare better are actually India, which has capacity on vaccines and drugs, and Bangladesh. Bangladesh comes out of the dark and starts delivering, COVID therapeutics ahead of India, So what you see is that there is a case to be made about, we can't go back to future pandemics with inequitable distribution of tools of manufacturing and technology or manufacturing. And I think that comes out straight out as a learning from this pandemic. And I'm not going to go into the numbers, and I'm going to stop here. And I also wanted to sort of say that what I'll leave for later is the accountability on the India side and on the part of Indian pharma, particularly Biological E and the Serum Institute, and how they behaved in the pandemic and whether that was actually looked at very closely. So I'm going to come back to that in my second round. Thanks.
Thanks, Leena. So in December 2021, I think the Partnership for African Vaccine Manufacturing set a target to raise local vaccine making capacity for Africa's total vaccine needs, which is estimated to be somewhere between 1.4 to 1.7 billion doses every year, from the current 1%, just 1%, up to 60%. So that they can look at reducing dependence on vaccine imports. But then they've set a 20-year target for it, also because of the enormous infrastructure ramp up that needs to accompany this kind of increase in the capacity of vaccine manufacturing units that they're planning to set up. So thank you for flagging up all of those issues of intersectionality. I think that's absolutely key. But Ranjit, let me turn to you now. You've written extensively on WTO negotiations regarding TRIPS as Bureau Chief India for the Interpress Services. And I just wanted to flag up something. It looks like we don't get to hear that much about what goes on behind the scenes with regard to these WTO negotiations and so on, unless there is a press conference or there's a high-level statement from a decision maker. So we see reports in the newspapers, at least, and let me talk about India. I wouldn't want to comment on the press in the other countries, but here what we see is, let's say we have our External Affairs Minister, Mr. Jairam Ramesh, speaking at the Foreign Ministers Summit at the G20, and he's going to talk, he was calling for greater international cooperation with obvious reference to India and South Africa's call, against the EU proposed framework, to sort of allocate access in a certain way. But then from one statement to the other, and this gets picked up by the press, but what happens between these high-level statements? What happens between the time that Dr. Ghebreyesus calls for greater vaccine equity, or we have Jai Shankar calling for better international cooperation? What happens between these announcements? What should journalists be doing to track the story between announcements? Ranjit, over to you.
Yeah. Hello, everybody. Yes, I think there is that gap. You have these announcements, and then it's partly also the job of journalists to keep track of things. You need to really be clued into things. And maybe when it comes to something like WTO and TRIPS, you need to do extra homework to know what exactly is going on. And that's becoming increasingly difficult because, India is not exactly a happy place to do journalism nowadays. And that's a problem because you don't have access to people. And sometimes you find that not everybody knows what's going on. Even people in government don't know what's going on. Everything seems to be tightly controlled in the PMO or something like that. And then they're not very happy to share information. Not because of anything else, but because they fear repercussions. Maybe they fear that a report might get them into trouble in some way. So it's become a very sort of, over the last few years, very closed kind of society. And that's unusual for India because we've always had a free press. I mean, maybe some people have described our press as being raucous or, not going its limits and so on. But this, we seem to have swung the other way. So that becomes difficult when you are dealing with something like COVID, which has become a hugely political thing. Internationally also, you talk about vaccine wars, vaccine diplomacy, and then you like to suppress information. I mean, we had this zero surveillance done by the ICMR. Now, suddenly they stopped releasing the results. So we were at sea as to what's happening, how fast is what's the level of antibodies within a population? We don't know. I mean, after a point. So now then we realize that this has to do with certain political compulsions. They want to run something like a Kumbh Mela, so they try to suppress it. And we have people like Jamir who resigned, partly because of the way they were handling stats, etc. So it's a difficult thing. Now, if you ask me right now, at the moment, I am very concerned about the budget. The outlay on health has been barely, I think, less than 1% or so, 45%. I have 0.45%. I still have to go back to that. But now, what do they mean by that? Are they saying that the pandemic is over? Have we fully dealt with Omicron? Or are you sure that there's not going to be another mutation? Are we prepared? See, Delta, we were completely unprepared. And for all these wrong reasons that I just mentioned.
Let me just cut in there for a minute to ask about, let's say I'm a reporter from one of the towns in either Bangladesh or Indonesia or Sri Lanka, any of the South Asian countries, and I wanted to understand better about the TRIPS-related negotiations, the tussle that is going on regarding intellectual property rights and patents, and where would I go to, who would I turn to get a better grasp of it, and how would I make that relatable for my audiences?
Well, that's a good question. Actually, in India, if you're in Delhi, there are issues like risks around this, this external affairs think tank. Now, if you're friendly with these people, they are willing to share information. They can be quite different from they're semi-official, and they have some.
No, it's
Sorry, yeah. So that's one thing. But if you're in a remote area, of India, let's say you're in a small town somewhere, the best thing that you can do to find out about WTO and stuff like that, IPR, etc., is to go and contact the nearest academic. See, you have a lot of colleges that teach economics across India, and this is an untapped resource. You can go and ask them, or they can find out for you that where are we standing with, let us say, IPR related to vaccines. Very often you find that the politicians haven't got a clue, unless they are people like Jairam Ramesh or somebody. But how many of us have access to Jairam Ramesh? Or how much time does he have to speak to you? I mean, if you don't know the basics, he'll probably ignore you. So that is you have to look around for what is available, and there's plenty of it available. That's number one. Number two, the internet is a huge source. You have everything on internet. There's no longer any excuse to say you don't know what's going on, because it's all out there. It's all out there. I mean, there are debates like ours on whether if you don't follow an IPR regime, then how are you going to generate money for your research, or you spend money on research? How are you going to recover that money? But if you understand that governments can underwrite your research for you. You look at Corbevax, for example. I mean, what is not very well known is that Biological E actually got $50 million somewhere in October of last year to upgrade their facilities. That's huge. I know that I think Madam Bottazi there, they complained that they didn't get a lot of support from the US government. But the fact is the US government actually did support Biological E on the other side. So how they negotiated that, I don't know. They're probably very influential. But that made all the difference to whether they could actually manufacture that vaccine or not. So we need to get the governments to go and back these private. I mean, it's one thing to say they're liberalizing, they're going to hand it over to private parties. But what are you doing about it? What are you doing? Are you arranging for the funds if you don't have the funds? You have the sorry state where, COVAX and other setups are actually starved for funds.
So what you're saying is, when we were speaking earlier, you said that there need to be a call from journalists for more frequent briefings from ministries concerned, so that there is if we're making a massive push for vaccine equity, or if India is trying to position itself as a sort of a beacon of vaccine diplomacy, well, they just have to let the media in on the action and keep us posted about what's going on. Thank you so much, Ranjit, for some pointers on how journalists can investigate the regulatory tussles that are impeding access to vaccines. It certainly seems that everyone, and not just some people, need to listen to their conscience. So speaking of which, Dr. Bhan, let me turn to you now. You've been engaged with the ethical aspects of health policy and vaccine policy for close to 2 decades now. And on January 17th, the WHO DG, Dr. Ghebreyesus, said more than 39 million doses of vaccine have now been administered in at least 49 higher income countries, and just 25 doses have been given in one lowest income country. And he added not 25 million, not 25,000, just 25. And he went on to add, of course, his oft-repeated quote that the world is on the brink of a catastrophic moral failure, and that the failure would be paid with the lives and livelihoods in the world's poorest countries. So, Dr. Bhan, in the race for vaccines, do you think that the voices of ethicists like yourself are being drowned out? And how often do you see journalists amplifying your concerns, and what are they?
Thanks, Jaya. Thanks for having me. Absolute pleasure to be here, and always nice to speak to journalist colleagues. So, today's World Cancer Day, and the theme for this year's World Cancer Day is closing the care gap. And the gap is huge in the context that WHO just today put out a number which says that comprehensive care, as in treatment, is available in more than 90% of high-income countries, but less than 15% of low-income countries. And so this disparity that we have in the world is not unique to COVID-19. It is a disparity which is fundamental about global health and the way our health systems have been structured. If you look at COVID specifically, a good friend, Kemantri, who's also an ethicist from South Africa, recently wrote a paper for Nature where she highlighted that this desperation, is not something which is new and only about vaccines. This is in fact true for COVID-19 testing kits. It's for personal protective equipment. It's for intensive care beds. It's for ventilators. So this story has been on since 2020, even before we had the first vaccine available. And even for any of these interventions and or technology and or devices, the preference has always been for countries which have purchasing power. And that is what should trouble us the most. So in a way, it is certainly an equity issue, but more importantly, it's a justice issue. And that's where the ethics part of it comes in. Fundamentally, if there are people who are getting access only because money plays such a huge role, then that is something which is deeply troubling. The fact that sharing of vaccines has been reduced to a charity exercise is something which is deeply troubling. It should worry us all because, this, as I said, is not unique to COVID, but it tells us a lot around how global power imbalances exist. And the fact that when you look at even R&D, and the fact, as was also being pointed out by Ranjit, that a lot of money which is gone in is public money, whether in most of our countries, including in India, but also certainly in the US and in the European Union, etc., that so many public funds have gone to help us reach where we are with vaccines, because R&D takes a lot of time for any vaccine, and what we've seen is absolutely a big win for science, but it has also involved a lot of money, a lot of scientists, a lot of clinical trials, a lot of participants coming forward and agreeing to participate in these clinical studies, which have enabled vaccines to be available. But at the end of the day, decisions around sharing and making vaccines available are pretty much left largely to biotech companies, to pharma companies, and sometimes to country governments, which have prioritized the needs of their own populations over sharing it with low resource parts of the world. So the fact that, as was pointed out right in the introduction, that there are many parts in Africa, more than half probably, where less than 10% of the adult population is fully vaccinated. And at the same time, we're talking about boosters and sometimes even a fourth dose now in some countries being discussed, is something that, again, from an ethics perspective, is something to worry about. Because at the end of the day, one, of course, there is a justice angle to it, but there's a public health angle to it as well. None of our borders are secure to keep microbes out. If our neighbors are not protected, if other countries are not protected, and we've seen this with almost all waves and all kinds of strains, whatever kind of border controls you put in, cases will come in. And if we allow for that situation to be there where the rest of the world or a significant part of the rest of the world is not protected by virtue of having access to vaccines, then you will always open up the possibility of another strain which might be more virulent, for which your existing vaccines might not be as efficacious, etc. So I think very importantly for journalists to highlight that how interdependent we are, and especially this pandemic teaches us that all of us need to recognize that and work with our own countries, but also ask these critical questions of global power politics, or to ask questions of why is it that when public money has been invested, that these decisions are largely left to corporations about who they allow access to technology, to know-how, and even ability to share vaccine doses. And if that is indeed the case, then perhaps it will mean that the next time we have a pandemic, we might be in a slightly better situation.
Thanks, Anand. I know that in December you spoke at a panel on the WHO Ethics Summit, and some of the ideas that came up during your particular session were how ethics can inform policy. And is there a way that journalists can go to a set of documents or specialists that they can speak with to kind of audit the ethics around a particular vaccination policy, or with relation to R&D or manufacturing, rollout, distribution, pricing, and so on? So is there a ethics index that ethicists can come up with that can track this, help us track it? There seems to be, it seems to be that you're flagging up things that saying it's all unfair, but how can journalists track that unfairness in a concrete fashion in the form of investigative journalism? Are there, there is a values framework, by the WHO, the SAGE framework, which spells out the values based on which vaccines are meant to be distributed and so on. So what exists really that journalists can look to, something to hold on to, because it's a very difficult thing to sort of capture?
So that's actually a very good question. And, there's been a lot of thinking because, as I was saying earlier, this is not the first pandemic and certainly not the first example of global health inequity and injustice. So there's been a lot of work right from SARS on, even during infectious disease pandemics, on trying to figure out what are the public health ethics principles at play, because they might be slightly different from, say, routine discussions around consent, around autonomy, around, beneficence, non-beneficence. So, but also talking about issues around transparency, around accountability, around governance, around the need for evidence-based decision-making, around not taking any decisions which violate individual rights without really, from a public health perspective, having a very solid ground. And all of these are well written into guidance documents. Even during this current pandemic, there's actually been a lot of guidance documents which have come out from committees which have been set up by the WHO specifically to look at some of these inequities. There are also unique issues. For example, is mandatory vaccination acceptable or not? And as you know, many countries have been playing around with that idea in India, and I'm sure in many other countries which are represented today. You have sometimes local governments which have played around and said, we will not give a salary to our staffers unless they decide to take both doses or the third dose, etc. But is that grounded in evidence? Is that grounded in ethics? Is it acceptable to do it? And if not, then what are the kind of ethical issues which are relevant here? So there is a lot written about it. There are guidance documents, there are frameworks which are available, and these should be easy to find. I'd be happy to also share it with anyone who's interested. But most importantly, I think it's also important to distill it down, because there are lots of elements of gray. It's not always white and black, and sometimes it is made to seem so because it's almost seen as being nationalistic to do one thing, or you have to, of course, prioritize the needs of your own country over, say, needs of other countries. But it sort of defeats the whole purpose of understanding from a public health lens the importance of actually being open and understanding of why we cannot really defeat any kind of a pandemic situation by only being nationalistic about our own needs. And I think if we get that, and if we use ethics for that purpose, that will perhaps help with the nuance and a better public engagement of these issues.
We will go to that ethical conflict between, the national and the global sort of priorities in the second part of the webinar. But thank you so much, Anand. I'm going to now move to our discussants. Let me start with Dilrukshi. Dilrukshi is a lawyer, a journalist, and the director of the Center for Investigative Reporting in Sri Lanka. And she has been following the IPR issues as well and has churned out some fine commentary on that. So Dilrukshi, some concrete guidance to journalists. What are we supposed to hold on to as we navigate this?
I think all of us are trying to grapple with this question practically, Jaya, but I think there are various vaccine trackers. I'll just throw some examples. I think they're pretty common. All our countries do have vaccine trackers. And if I were to just give an example from Sri Lanka, so 36 million doses administered as of now. And this is 13.9 million fully vaccinated. This is also 63%, over 63% of the population. So when you look at the entire country, at least with one dose, then we are doing 76%. And it does look good, right? When you look at South Asia. But on the other hand, this vaccine, through the vaccine trackers, you can get this data. But beyond the data, I think lies the real story. And one is about the South Asian story, because I'm passionate about that. So Afghanistan has 11%. And Nepal is 53%. Now, when you just even do a very cursory kind of comparison. So there is obviously a serious question of lack of access, equity, affordability, and how pricing impacts our countries. So these are pretty difficult ones to navigate. So I think one of the things is that this also drives when there is not enough good information out there, and information is so important at this moment because we are making very vital decisions about our own health as communities, as countries. Where do we find the information? Beyond the vaccine trackers, looking for information has been a difficult one. And that is because we are looking specifically for the kind of information around efficacy, affordability, and access, whether there is a deep rural-urban divide. And clearly there is. And then there is, in our part of the world, there is great politicization. So prioritization is also not based on where there is, cases increasing. Kind of prioritization is not the way it has happened. Sri Lanka is a case in point. And all of this, plus the fact that good information is not available in the public domain, is creating serious problems for journalists to go deeper, because first we did not know how to report it when it happened. And then you go a little deeper and try to navigate the question. Now it is about how much do we pay, where do we buy it from, and who holds the rights, and what are the kind of vaccine diplomacy involved in this? Why do you buy a particular brand, or is there a reason for doing that? And who tells us about the efficacy? Don't we, as people who are going to be vaccinated, have a right to have this information? So I think one of the tools that people should practically use, because most of our countries do have this tool, is to use the right to information laws that we do have. I think we need to really push it, because we do have the right to ask this question, because it is in everyone's interest. So about supply, delivery, and then our buying power, distribution, and also different countries having weak healthcare systems. Some have better healthcare systems. So how does it all happen? So I would say we should try to use the tools that are available, look at a way to do the data crunching. There is this kind of, all kinds of data is there, but how do we actually look at the affordability and availability and access? We all know marginalized people are getting further marginalized. And even now, some countries are having the second dose, some countries are onto the booster and onto the fourth. So who's deciding these things? Why does it happen? And who drives also vaccine hesitancy? Because that's the other point. I think disinformation has played a huge role. Misinformation has played a huge role in driving vaccine hesitancy, because people do not have the information. People worry about it, and we need to break that open. Thank you.
I think those were great points, Dilrukshi. And as you were speaking, it almost came to mind that if we erased all the international, national borders, then you would see a better picture of vulnerability, I think, no? Where it's concentrated, and it need not necessarily be along the lines of a state border or a country border. We might get a more humane sort of a picture of where vaccines need to go if there are no borders at all on that map. But thanks also for those very, very practically useful pointers. It seems like unless journalists speak up and demand information, or the kinds of information we need on a regular basis from decision makers, either in the Ministry of Health or otherwise, or from, the industries, whoever is in charge of vaccine manufacturing, unless we keep pushing for regular briefings. I mean, we are in a protracted public health crisis, and unless we push for those regular briefings and keep the story moving from our side, and instead of waiting for stories to come to us, which is very convenient for us several people, I think we'll be able to do a better job this year. So I'm going to ask Megha Kaveri, who's done quite a bit of reporting, been after some good investigative stories on COVID-19 in Tamil Nadu when she was with the News Minute, and who's now studying global health and migration in Geneva. Megha, what are your thoughts on how migrants have been sort of reached with vaccines, or what else do you have to offer in terms of practical tips for how journalists can do a better job of covering access to vaccines?
Thank you for the opportunity. On this topic, I have 3 pointers to say. One, in relation to migrants, one of the biggest problems, practical problems that they are still facing in a lot of pockets, is that this emphasis on digital inclusion. If you want a vaccine, you need to have an Aadhaar card. If you want vaccine, you need to be registered with COVID portal. And I think all these things are sort of counterproductive, and it prevents people, migrant population, the most vulnerable sections of the society, from accessing the basic right to have a COVID vaccine. And there is obvious difficulties with the data privacy and all those things, which even the most privileged sections of the society are facing in relation to the vaccine drive in India. But in my opinion, in order to access basic healthcare rights, this digital emphasis is becoming more counterproductive than than achieving any merit. And another thing is that so in order to cover and in order to facilitate that the most vulnerable sections of the society are covered with these vaccinations and all the other things, it would be better to organize walk-in camps and mobile camps to push the healthcare agenda, the public health agenda among those people. The second point is that media coverage in relation to public health and global health, in my opinion, should not just be about the vaccines and why it's not being accessible to people. It should also speak more about how regular healthcare delivery is being affected because of the pandemic. Pandemic, yes, it is an emergency. Yes, it is an emergency that transcends borders. There is no second thought about it. But then there are people who are already in some sort of a regular health monitoring program, like programs for HIV, programs for TB, and even those people who have cardiac issues, who have regular consultations with their doctors. And because the infrastructure was overwhelmed with an influx of COVID patients, all the other things took a back seat. So this is something that we have to hold the government accountable for. Over the years, what have you done to improve the infrastructure? What if there is a pandemic? We all seem to be in a consensus that this is not the first pandemic, and this is not going to be the last one either. So moving forward, if there is going to be another pandemic of a similar severity, do we have the capacity to service everybody regardless of what health issue they are facing? The third question that journalists can ask is, what have countries like India and South Africa, which are rightfully pushing the WTO agenda, done to increase capacity in their own countries? At least in India, since I reported in Tamil Nadu, I can say that there is a big vaccine manufacturing facility that's lying idle. What has the government done to do that? Apart from, even in the media, it was a buzz for what, 1 month, 5 weeks maximum. Everybody asked questions and then it just went away. I understand news is a cycle, but then these things have to be, we have to be persistent in asking questions and bringing this to the fora again and again and again for some policy change to happen. And Bharat Biotech vaccine, if I remember correctly, it is a collaboration between ICMR, NIV, and Bharat Biotech, which means that there is considerable public money going on into the research and development of that formula. What has the government done to open it up and push it to other manufacturers as well? Government can do such small things even to ramp up vaccine manufacturing capacity, thereby increasing the production in the country, so that tomorrow they need not hide between, hey, we don't have enough vaccines to administer to everybody, and hence we are going to do it section by section by section. Because in this approach, what is again happening is that it is the most vulnerable population that is getting sidelined. Even when we go section by section, it is they who are getting affected time and again. So we need, I think we need a multi-pronged approach and a good overall of how we think of approaching the system. And I think journalists can play a good role in bringing all these issues to the fore and keep bringing these up, not just in times of pandemic, even in regular times.
Yeah, thanks, Megha, for those great points. I think, sustained pressure on governments and decision makers to really start investing in our chronically, unattended to health systems for starters. And also you flagged up issues related to pricing and the use of public money, just like Anant did. So thank you so much for those tips. I think it's going to be a neat segue to what Patralekha is going to say, because Patralekha, you're really passionate about some of the communities that may not ever see a COVID-19 vaccine, notwithstanding these high vaccination coverage percentages that are being flashed in the media. So what are your thoughts on this? I think you're muted.
Okay, can you hear me now? Can you hear me now?
Loud and clear. Yes.
Okay, well, thanks for having me, and good afternoon, good morning, good evening. And it's very interesting because I've been writing on this for almost 30 years, and I think the fact that I've written for Intellectual Property Watch, which used to be a website in Geneva, it still exists, for years, that really helped me. And to me, the media has a very important role, because in South Asia, as Dilrukshi also mentioned, we don't have data on a whole lot of issues. And then the data we have is not good enough, right? And the way I see it, and is, we talk about sources. Now it's great to see actually some of my key sources in this panel, Leena and Anant, whom I keep bothering every now and then. And I mean, to me, the three key words are justice, equity, and I'll add another one, enlightened self-interest. And I think they are actually intertwined. And I write on health and justice and equity. And I think everything I see when I write is through this equity and justice framework. And when you see India, and I think India, if you don't use this lens, you basically cannot report on India or huge parts of the global south, because this is the organizing principle. When you see that, then and not just vaccines, on anything, on any health statistics, aggregate average figures are useless. So, for instance, now it's wonderful that the Indian government has vaccinated as many people as it has, but as in everything, that one figure doesn't really tell you the full story. What is the marginalized groups. So even when we've reached, let's say now I think reached about 2/3 of the population, but now that's wonderful. But it's always been the case, and not just with vaccines, who are the ones we haven't reached. And I think just a couple of days, I came upon a story. It's a concrete example. It's actually one of the Indian websites, Quint, I think, has reported. Now in Hyderabad, in the outskirts of Hyderabad, there's a district called sorry for my pronunciation, Medachai Malkajgiri, right? Now they have 79% population fully vaccinated. Right, again, adjoining district, Vikarabad, has nearly 26%. This is not even interstates. It is within the same state, adjoining districts. Okay, look at the National Capital Territory where I live in Delhi. East Delhi over 90%, North Delhi 38%. Now these are stories. Now the point is, once you've got that equity prism, you may not, this should flash. Why are these different figures? And if these figures are not there, Why are they not there? When you go into the official website, you don't always get the disaggregated figures. And if you take the aggregated figures, it really, you only know very little of the story. So then why are these gaps? Contiguous district. This is true about every health indicator, not just vaccines or anything. Education, look at anything, nutrition, contiguous districts. It's not just between states or between countries. So, so for instance, what are the reasons? One is, of course, the remoteness of terrain. When we talk about marginalized groups, tribal areas, it's the same reason why somebody living in a remote tribal district or area doesn't have access to, it's basically access to healthcare. They also don't have access to vaccines, right? These are going to be the last mile challenges. So while we do celebrate, we have to focus on this. The other thing is, the vaccine coverage is plateauing a lot. Now, why is it plateauing? Why is there vaccine hesitancy? It's too simplistic to say because they're poor and illiterate. No. You have to try that much harder. We saw that those of us who covered the polio thing, there were 4 districts. Now, what was the reason? It's very easy to say, well, because they were Muslims, and they're illiterate. But why was there a vaccine hesitancy? Why didn't they want to take it? Now, when I was covering the polio thing, I remember people say, you don't care about us, how we die rest of the year, rest of the time. Why do we want only because of polio? So there are lots of these things. When people don't have access to basic healthcare and they would have lack of information, about vaccines, forget about even poor people. Very many middle-class people they've taken 1 dose and they think the second dose is not necessary. So you need, the same sentence when you put out a message. It's interpreted in different ways by different people. So I think it's extremely important when it comes to the marginalized groups to ensure that people understand what you're trying to say, health messaging. So people, like I said, 1 dose, they think it's sufficient, so you don't have to take it. Inadequate understanding of vaccine-related adverse events. You have to put out this information. I think it's actually nationalism and patriotism to talk about the things which don't work. That's how you build up credibility, not just by putting out a completely, a triumphal picture. These are the constraints to hesitancy. And then, as has been mentioned, I think, by many people, and it's across South Asia, for women, for instance, there's a gender gap. More men have been vaccinated in India. I think it's narrowing, but it's still women. And now why is that so? Because women, it's the transport. They need to be escorted. They don't always have the phones. So these things, these are actually social determinants of health. And, these, I think, have to be, and as journalists, I think what we can do is, this is the national picture. Internationally, the same story is happening. Africa, it's been mentioned, and I think even within Africa, there's inequities. It's not that Africa is one country. I think there's a Twitter handle called Africa is not one country. So, you have to go into, it's not enough to just use buzzwords like Africa, continent, or global south. Why are there the differences? And as I said, once you know what the issue is, I mean, MSF is a great source, for instance, Médecins Sans Frontières, as I said, when I was writing for Intellectual Property Watch very often, and now with internet, you can actually access people. So, in Africa, I think Mauritius and Seychelles, I think more than 70%, whereas there are countries with less than 10%. What are the questions, and bringing back to the last point, the enlightened self-interest. I think a big problem is, like it was mentioned, that some people are getting 4 booster doses, and some people not even got 1 dose. Now, it's in the interest of even the rich people in the rich countries or the rich people in the poorer countries to see everybody else vaccinated, because you are otherwise huge numbers of unvaccinated people would mean that there will be more new variants, and then even if you don't die, you'll be quarantining, self-isolating, economic disruptions. So I think this enlightened self-interest angle, also journalists have to flag this along with the justice and equity.
Thanks so much, Patruleka, for those great points. And I was reminded when you spoke of the disparities in the vaccination coverage figures between contiguous villages or districts. It really reminded me of someone who once said that you can drown in a lake with an average depth of 4 feet. So I think we need to really dig deeper into the data to give a more realistic picture of what is going on. And I think it's these small stories, small in-depth field level investigations that are really missing from our reports on access to vaccines and the inequity issues. So we look forward to more on that. But I do know that we're sort of limping behind a time that's getting away from us very, very fast. So I'm just going to move quickly to the next segment of this discussion, where we're going to look at some in-country realities. And let me go back to Dr. Bhan and I'll ask you about something that the media has been reporting about, but not in depth. And this is India's backing out of its promise to supply vaccines to COVAX, which was a decision that effectively left the COVAX short of about a quarter of its of its global commitments, and many African and Latin American countries suffered as a result. So whether it's the North or the South, it seems that countries are following a principle of moral nationalism rather than moral cosmopolitanism. And we heard all our discussants, sort of shouting themselves hoarse over this. So what kind of reporting do you think? I mean, we should be doing? Should we be, as Ranjit said, flagged up, be able to forecast these events better? Like, why weren't we able to forecast the Delta outbreak? Why weren't we able to? Was the surveillance missing, or what needs to happen for countries to plan better to keep to their commitments? What are the ethical issues there? Anand.
Yeah, thanks, Jaya. So I think what you asked is a whole bunch of issues, but they are clearly interrelated. Let me maybe take on one of the elements, which is transparency. One of the things I think many of us who are in public health have been struggling, and actually I think journalist colleagues have been struggling, is just trying to understand, what really are we dealing with, say, at the local level or country level, state level. Do we really have a good handle on, for example, what was the true case burden? How many cases did we have? Do we really know truly how many deaths did we have? The trials which happened, do we have open reporting mechanisms? The decisions which are taken about which vaccine, the committees which are involved, is the membership publicly available? Is the rationale for decisions available in the public domain and or not? And if this is not available, then that's the right set of questions to ask. Why is it that during a pandemic, when we should have actually more transparency to enhance trust, that we've actually seen a decrease in transparency? Then you look at issues around, let's even start with test kits, because test kits is something which is interesting. If you can ask these questions around, why is it that we had limited number of tests happening in many states, especially early in the pandemic? What were the kind of test kits which were being used? Were these available? If these were available in the private sector for purchase, then what test kits were available? Were these of quality? Why is it that you have monopoly agreements allowed for testing, as you have seen in our airports, which are just making a killing of anyone who's traveling internationally? Remember, it's not only middle class and upper class which travels internationally. Sometimes it's migrant labor as well. But the fact that you have to spend an enormous amount of money to be able to travel tells us something. And at the end of it, there's been some really good reportage recently talking about the quality of these kits as well. Are these really, are these test kits reliable? Do they have sensitivity? Do they have specificity? Similarly, if you look at vaccines, I think it's good to also ask that, while we should certainly celebrate, especially in India, the number of vaccine doses we've been able to give out, but we have also to ask what might be segments of the population who have not yet been reached. So Megha talked about the whole COVID issue, technology, need for ID cards, but it's also, there are a fair bit of sections of the society which might be socially disadvantaged. So also with support from Sabin Vaccine Institute at Sangat, where I'm based, and with other collaborators, we've been trying to look at access issues among marginalized populations, so persons with disability, transgender communities, and trying to understand what were the enablers, what were the challenges, because that's the kind of data that we really need to understand the impact on traditionally marginalized communities. Because if we are not able to reach those communities, then there is a problem, because they might be actually among those who are highest at risk. Another good example, persons with serious mental illness. There is now enough data through the pandemic to demonstrate that persons with serious mental illnesses are at a much higher risk of disease and death But then in our priority list, which came out early in the pandemic, why is it that they were never named? And if they were not named, then on what basis or on what evidence base were you taking decisions, right? Because then what's the rationale there? What is the appeal mechanism there? If I represent an organization working with persons with serious mental illness, who can I approach and say, no, I want my group or community to be represented in this list because they are at a higher risk? Were those mechanisms available? And if not, then why is that not the case? So I think if these kinds of issues could be raised by journalist colleagues, that will help, because then it takes the voice probably to the policymakers, and hopefully will mean that there is actually a requirement for more transparency and honesty from policymakers, and that we are all better informed. Because when we build that trust, I think issues around even concerns about taking vaccines, etc., can be much better addressed. And it's very easy to paint it as vaccine hesitancy without really understanding some of these dynamics of why people hesitate or why people might be concerned about taking vaccines. And I think Patrulekha was absolutely right. If this is the first time we are launching an adult vaccination campaign and you're going around chasing people to get vaccine when the health system has never touched them, then of course they will have legitimate questions. Where were you when we needed you for a whole lot of other health needs? And suddenly you only want us because you want your vaccination numbers to be high. What about the rest of the health system? Where is that, right? So I think those are all good questions to ask, and hopefully we will see more of that happen.
Thanks, Anand. Those were great sort of observations. And it struck me that it's also important to follow the work of scholars who are studying some of these issues. Access to vaccines among certain populations, like among women or among people with a mental illness, for instance. So if there's access, I was dreaming of a website where people just like a clinical trials registry. It's like a website of different scholars in different South Asian countries who say, this is what I'm working on, and this is the equity issue that I'm focused on. There's a chance for journalists to sort of go there so that they can access these scholars and people working in the field to go after these stories, and also get access to a reliable evidence base. So thanks so much, Anand, for those points. And I'm just going to quickly turn to Lena for what you think are the major in-country issues to do with transparency and access to vaccines. I know they've been flagged up by, in various forms and ways by the speakers who have come before you, but with specific focus to this whole, IPR issue. Is there anything? Lena, over to you.
Yeah, so my sort of, my hand is itching because there's so many stories in COVID. The whole story of antibiotic resistance, how we've used antibiotics as water. You can do a story on the way the civil society and NGOs facilitated access for marginalized communities in certain pockets of the country. But you could go on. But what I really wanted to focus on what was the narrative around India. So the narrative around India started with this great cheer that the Serum Institute had got a license, and the technology from Oxford, and then subsequently the license from AstraZeneca. And Serum Institute and Adar Poonawalla became the heroes of the Indian press. The second narrative, of course, was that India would supply COVAX, and the high-income countries, I think almost, you can say the international foundations all sort of said that, don't worry, COVAX will have enough. You've got the Serum Institute producing these vaccines and a couple of others producing the single dose, for example, from J&J, like biological E. So that's the narrative we hear. And then what people don't talk about is that in a pandemic, you have two standards. You have high-income countries saying, we're going to vaccinate everybody, all adults. And then you have the WHO saying, well, you need to vaccinate your vulnerable populations, elderly, and your healthcare workers. And in the Delta way, the mathematics went wrong for India, because at that point, India realized they needed to vaccinate everybody. And COVAX, and of course, Nepal and many other countries were in trouble because suddenly supply from India just shut down. But what is very interesting is, and I think what a lot of Indian journalists sort of missed, was that was it enough that Serum Institute was the only one producing the Oxford vaccine? Why is biological E, sort of having the license from J&J for the single dose vaccine? Why are Indian companies going exclusive when, in a number of cases like HIV, they have, produced HIV medicines almost like a consortium? You've had multiple producers, making HIV drugs, you've got Hep C drugs. That model of competition, even among Indian companies, has worked really well. that model is sort of broken down. And then you have the Indian monopolist sort of coming in, which is the Serum Institute, so to speak, which had a monopoly on the Indian system. 90% of what India has used is, Covishield. That story actually hasn't been broken down about the Indian monopolists. The other story of, how the media reported on the aspects, for example, Biologically is a very interesting issue for me, because Biologically is an interesting company. It makes very good products. And you see them come out with several in the pipeline. They receive public funding. They receive support from the Baylor Institute. You got all this support going to the Biological E, but Biological E itself refuses to answer any questions. Absolutely no questions answered by the Biological E. And I have one question for Biological E. If the patents are waived and you got the technology from Baylor, will you give your data that you have developed this Corbevax vaccine to other suppliers and manufacturers in the developing world? So, we are all cheering what has happened on Corbevax, but we're not asking those questions to say that is the monopoly that, Biological E have on the data relating to Corbevax, is that going to be transferred? The manufacturing process is going to be transferred. So we got these heroes in the Indian press. Then I want to talk about, the very interesting article in the Economic Times when, the Bureau of Investigative Journalism broke a very interesting story internationally about how Pfizer and other companies were insisting on certain conditions for supply of the vaccine. So one of them being to sign over sovereign assets, to be not responsible for anything that goes wrong with the vaccine or vaccine supply, and several other conditions. And I thought that was some stellar reporting coming from the Bureau of Investigative Journalism. When the story broke in India that Pfizer and Moderna and J&J wanted these conditions to be, they were secret. The Indian government didn't say what conditions, but all three insisted that the Indian government give them indemnity and other conditions. And the Indian press was reporting, yeah, they should sign it. No one went back to the Bureau of Investigative Journalists and said, hang on, what were these conditions that Pfizer had been imposing on, say, Latin American countries, and these countries were objecting, So I think the Indian press lost a lot of good opportunities along the way to report very interestingly in the pandemic. Last thing I wanted to say is more recent events that, perhaps have gone unnoticed by the Indian press or the South Asian press, particularly Bangladesh and, India, is the fact that, there's an intellectual property waiver on the table. So everyone in the Indian press had this attitude when they spoke to me, but that's never going to happen. Well, it's likely to happen, which is very interesting, that the Indian press's attitude was, this is too radical a proposal to win any support, while the proposal has grown and grown and grown and seems to have reached a point where negotiations are starting to happen. Just one point I wanted to make is the Geneva Health Files has just reported that they want to go ahead with the TRIPS waiver, excluding China and India. Who's reporting on the Indian press? No one. The biggest story, the biggest supplier, pharmacy of the developing world, will be left out of the IP waiver. Makes no goddamn sense, but no one in the Indian press is reporting it. Geneva Health Files, which is possibly read by only people in Geneva and a few others in the public health movement, know about it, have broken the story. And the last thing I wanted to say is therapeutics. Molnupiravir. People have reported about how Indian companies have obtained licenses, the debate between ICMR and whether it's going to be included in the public health system or not. But if you look at the real concern about Molnupiravir is that the misuse of the drug could lead to more variants that could be hugely harmful to the revival of the pandemic. No one in the Indian press has gone to Science or Nature and other reports that are coming out on Molnupiravir. And I can show you prescriptions which are being the misuse of Molnupiravir. So the Indian press is repeatedly missing stories that are being reported elsewhere. So I find it very interesting that Indian journalism, which was quite interesting at one point in sort of challenging the global narrative, has suddenly turned inwards and is only looking for stories in the Indian context. They're not making the dots and the links that would make them more sort of, globally relevant as the South Asian media. And lastly, I wanted to say is this, that a huge shout out for Bangladesh. Tremendous job on COVID therapeutics. It's the big story of the year for South Asia, that the Bangladeshis are producing almost every COVID therapeutic in the absence of intellectual property barriers. They are doing what Cipla did at the beginning of AIDS. And I think that's also a very interesting story because there's huge skepticism about Bangladeshi generics, as there was about Indian generics at the beginning of the AIDS epidemic. And I would say that, we owe it to Bangladesh to report a story that is, bound to make a huge impact on access going forward. So I think there's tons to do with the Indian media. Thanks.
Thanks, Leena. I mean, not just the Indian media. I think you flagged up so many stories that require greater attention, diligence, and hard work on the part of journalists, because these are just not just stories as ends in themselves, but they're like happening as we speak, and they will take on new forms as we go forward. But if we don't take note of them, I mean, that things just may not happen. So we have a chance here again to be proactive and inject some energy, enthusiasm, and hard work into this whole thing. So I know, Narayan, that I did jump the queue a bit, so I moved straight to Leena because I knew that some of her comments were more in line with what Anand and Patruleka was saying. But let me come to you very quickly to talk about what the in-country reality has been in terms of vaccination rollout. I mean, we've talked about manufacturing capacities and we've talked about, inequities in access. But when a country tries to roll it out, what's actually happening and what do journalists need to track as vaccination rolls out in a country? And could you share some experiences from Nepal? Narayan, over to you. Great going, Leena.
Yeah, thanks. Let me share. I have a very quick slide. Just before that, thank you, everybody. This is really exciting, and I know we are running out of the time, so I want to be very brief. Just to add on what Anandji said about this, ethical thing. So there's one resource, maybe useful for the journalist, what they called it, Index for Public Integrity, which is developed by the ERCAS in Germany. So this is really about whether you just keep tracking corruption or you want to find a ways that, building sort of integrity and sort of values in whole system, not just in public health, but, issue around governance and all. With that, I will just jump into my presentation. Let me give you a brief, statistics about how the Nepal is doing in terms of vaccine administration. We started nearly a year ago. The first jabs were introduced in, January 27th last year. And until now, until day before yesterday, we have given more than around 50% of people the full doses of the vaccine. We still have more to go in terms of, reaching our targets by mid April 2022, which seems not achievable. But in terms of the other countries, progress, I would say Nepal is not that far behind, but still there are issues about, accessibility and accountability. If you look at the data around the provinces, Gandaki province, which I don't know if you ever been to Nepal, you have visited to Pokhara, one of the beautiful city there, seems far-reaching versus there's one of the lowest province, which is Madhes province, even though it's very, it's highly accessible in terms of, physical location. But again, in terms of the vaccine administration, the data is really, really low. And there are issue about vaccine hesitancy, in the social backwardness, poverty, and education and all, but which we can discuss later if you have time. To do so far, we have received about 40 million vaccines. Almost 30 million from donation, which is great, and 12 millions from the purchase. I just thought why not to also give you a little bit idea about how much money that Nepal government has allocated for the overall COVID response, including vaccination process. So far, 69% billion rupees has been allocated, and out of which about almost half of the money were allocated for vaccine process. And if you look at the progress, we're only about to spend 6 billion rupees. That shows the inability of our government. It's and this raises a question about it. Often we talk about there's no resource, there's no finance, so that we are not able to purchase. It's not really about the resource, and here it clearly shows that it's really about the leadership and the political will. The money doesn't bring everything, but you need a good leadership and leadership with integrity. So, and in terms of vaccine access and equality, I totally agree with our previous speakers, and I don't think I have to add here more. But just one example that I have here, and one of my colleagues shared, and he had an opportunity to chat with a woman. She lived in Kathmandu, but she's from the rural areas, and she hasn't got vaccinated yet. It's because she doesn't know where to go, how to get it. People, the government or neither the government nor civil society or media has reached out to people like her to tell about the vaccine and how to get it. And there are other issues, like in terms of distribution, there is a disparity. You can see some of the districts have more than 100% vaccination rates. However, some are still below national average, which is about 48%. And some people have, in some areas, mostly in the urban areas, people have got double doses, and they also started getting boosters doses. But there are people who haven't got the first dose at all. To give you another, the issue why there's a low vaccine rates is one of the issue that we also found, in the media and through our networks discussion is obviously a vaccine hesitancy. And I totally agree with our previous speaker that, we often just say vaccine hesitancy, but we don't really try to find why there is an hesitancy and why these communities doesn't prefer, going to get the vaccines. So there are underlying causes and which we need to address. I think this is where the journalist can play a real role. And this is where the journalist can bring the stories of why there's a woman from Muslim community, for example, or where there's a woman from, ethnic background, or a man is not willing to take the vaccine, right? We haven't had the stories from people with community, from the people with disabilities, LGBTQI. The more stories we need to bring out and to really have a discussion and dialogue. And I think the first step is to get that information out, and where media friends can help. And there are issues about the after effects, like fevers, allergies, pains, which is not really really discussed and really have enough data to know about the real effects, and have a really nationwide campaign to debunk those issues if there are facts that can help to boost the motivation among publics. And then there are always the government is always trying to create confusion and chaos, and there is a contradictory in terms of government's own information dissemination and vaccine. For example, they were saying that they're going to give the booster doses for those who get the same vaccination at the beginning, but now they are opting for next one, is simply because they could not manage. For example, AstraZeneca, that's the first vaccine that we have given to the people, and now there's a time to give a booster doses, but there's no enough AstraZeneca. So here's what I want to focus more on journalism, and this is my last slides. So first of all, I think the media can bring the issue about the vaccine procurement. There's a lot of irregularities, supply shortages, and there's and there's an issue about lack of coordination, cooperation, collaborations, and planning on purchasing, distribution, and sort of storing about vaccine. and we haven't had enough data about it. We don't have enough information about it. Of course, there are some stories came out. We have a friend from Kathmandu Post who is joining here now. He has tried to bring a lot of stories out. But I would also encourage, the media friends to keep following those stories, to keep following those information, and just to make sure that these information are authentic and bring to the top, to really create a larger dialogue, the discussion about all this, gaps, including, corruptions or infrastructure issues. And there's one important issue that we have also faced is when you don't have data, about ethnicity, age, gender, disability, minorities, communities, in terms of whether they get vaccine or not, how they get it, at what rates they get vaccination. If there is a hesitancy, we don't know which community has at what level of hesitancy. We're just talking about there is a hesitancy in some communities, but we don't know. So if you have those, disaggregated data, I think that would open a huge avenue for larger debate and discussion. And finally, as WHO, I have seen somewhere in the WHO website, it says that, we have to abide by the principle that no one is safe until everyone is safe. So let's focus on that. And the transparency and vaccine campaign, from the procurement to distribution and storage, needs to be there. That's where the media can play a big role. And for this, we are saying that media need to play a big role. Media can play a big role. But how can we support our journalist friends? Is there a freedom for them to write independently? Is there enough resource to do the investigative journalism? Is there a protection mechanism, safeguarding mechanism for the journalists? How can we all, from the companies to international organizations like Internews and Accountability Lab, Sovereign Institute, can create a environment where the people from the media who are dare to get the stories out get enough support. So I think let's give more support to the journalists and let the journalists find the authentic information and put it out there to really create a larger debate around inequalities that we all are facing, from global south to north and east and west. So yeah, I want to stop here. Thank you.
Thanks so much, Narayan. And I think the Accountability Lab has been doing a great work together with organizations like Transparency International, so on. And these are the organizations that journalists really need to keep in touch with in order to get some insider stories and some authentic data related to greater transparency around access to vaccines. So thank you so much. And I'm now going to turn to Dr. Maria Elena Bottazzi, who's been very, very patient. And we're so privileged to have you join us. And congratulations again on being nominated for the Nobel Peace Prize, together with Dr. Peter Hotez, Dean of the School of Tropical Medicine, Baylor College of Medicine. And both of you have been not only vocal about changing global paradigms to bring about COVID-19 vaccine equity by, I quote, decolonizing global health. You've actually gone ahead and been an example yourselves, gifting vaccine know-how to countries in the global south, starting with Indonesia, then Indonesia, and then where next? So do share your journey with us. Over to you, Dr. Bottazzi.
Well, thank you very much. First of all, it's been a pleasure to just listening to the conversation. I think you all are pretty much rock stars, because this dialogue is important, right? Because this is how, indeed, by engaging, the journalism sector, we can really voice what really is happening and ensure that we have all the real information out there. So to put in perspective, and again, the center that we have been directing with Peter, which has more than 20 years of in operation, and in fact, we used to be linked to the Saving Vaccine Institute. So thanks to them also that they shared my contact to be with you today. But now we have been 10 years, believe it or not, already down here in Houston, in one of the largest medical centers. So we are embedded in an academic health system. which makes us, of course, unique in itself, because at the same time that we are advocating for open science, we're also our teachers, right? We train, we educate, we share our information. And that's why we've always had this notion of you can do biotechnology development in the context of academia, but by breaking a little bit this paradigm that the discoveries that come out of academia don't only need to be transitioned into big pharma or big biotech companies, that we have a role in co-development, and we have a role in the fact that now we can even delink some of these research and development activities through these university consortia and relationships, to also, like we said, right, decolonize a little bit, because of course everything we do academically, we're charged to publish, and we're charged to basically, try to be open science. And really the idea of why we wanted to keep it this way and working like we basically call ourselves a money-losing guaranteed company, to be quite honest, is because we've always been trying to advance, in our case, vaccines primarily for neglected diseases, which we know from the start, they would not have certainly economic incentives, and most likely, very unlikely, big pharma would pick up to try to develop these interventions, mostly because they're diseases that would come to solve diseases of poor, and they're not diseases that are killer diseases, they're morbidity diseases. And to name a few, for you who may not know what neglected diseases are, it's all sorts of parasitic intestinal worms. We have Chagas disease, leishmaniasis, schistosomiasis, hookworm, ascaris, trichuris, and so, of course, to be quite honest, at some level, the emerging infectious diseases maybe sometimes even be categorized as neglected, because unless there's an outbreak or a pandemic like we have now, they're definitely not even considered, right? Because they're the unknowns. So we knew that to enable and to induce and incentivize some hope that we could develop these vaccines for these NTDs, the first thing we did was, of course, we said, there's no point of blocking intellectual property. Nothing that we do anyway is like any major earth-shattering. And in fact, what our goal is that, even if we have an earth-shattering discovery, let's say, for example, we actually do use RNA technology for our Chagas program, for example, but we do it in a way that we eventually, the aspiration is that it's being actually produced, evaluated, and eventually delivered and used in the countries that these diseases are the most, prevalent. So that's why many years ago, in fact, I've been in India multiple times, kind of, visiting all the manufacturers with the hope that maybe one day one of them may be interested in producing the hookworm vaccine or producing the schisto vaccine, or, and of course we lucked out that, in fact, I think one of the points that, maybe was Lena or one of you were mentioning is, how do we really enable that, if you hear, the experience of the initial response of Serum Institute, of course, with AstraZeneca, and yes, Biological E, their relationship they have with J&J, but they're not indigenous to themselves. They're really, receiving something that somebody else is giving them, right? And to sometimes even partially do things, I know BioE was most likely more the filling, finishing, or maybe some of the production. I'm not really familiar with all that. But the fact that we also need to enable indigenous production, right? That they maybe come up with their own product that then they could indeed, if they are interested, share with other producers or not. But our intent was always that our formula is out there. And even if you didn't want to call us, you could reproduce our formula, right? Because these manufacturers, as long as they have the capacity of the technology, which in our case, we also selected technologies that we knew they're already out there. They were not innovative in itself. That would be difficult because of the learning curve. That even if you remove IP, you still have a learning curve that you have to transpass. We knew that anybody, for example, that could do yeast production, if indeed they have, for example, the hepatitis B production capacity, they could possibly read our paper and just redo our vaccine. And it was very interesting, however, that we actually didn't really have anybody like lining up and saying, oh my God, this is like revolutionary. It's so easy, cheap. We already have the capacity. We don't really have to invest too much because it's kind of like repurposing a little bit the factories and maybe the personnel and even the consumables, because they most likely already even have them in stock. And nobody really jumped to the gun, right? You know, except at the beginning, and I honestly very transparently tell you, Biological E was the only one. And they had a vision, and you know, of course I cannot speak for them, but I believe they had a vision that yes, they were of course working in their normal realm of business, right? But at the same time, they really wanted to have something indigenous, right? And I know that I've been hearing a little bit that you're saying that they were beneficiary of the US and the DFC and CEPIs and whatnot, right? But it was pretty modest, and most of it actually was directed, I believe, towards the J&J relationship. It wasn't really directed towards their indigenous, aspiration of Corbevax. I think we have to make it very clear, right? Because there were some engines of, loans and whatnot, but it had to be very specifically linked to also products that were WHO EUL'd or, that had some level already of relationship with these multinationals. And so we have to put it in context that, the work that we've done with BioE really came from the arduous work of our scientists with their scientists, and our contribution really was, yes, it's all published. You can probably do it without us, but we have a lot of behind the scenes know-how that at least we can offer help, right? And sometimes we did, the animal study that was pivotal that, they wanted us to do because we were faster than maybe they collect the data, or that we, for example, now we have all sorts of toolbox of seed banks for all the variants that you may imagine. And, sometimes they just want to have reagents that they might want to use. And it was really a transparent, iterative process where, it's their vaccine because we gave, them, non-exclusively, but it's their vaccine, and Corbevax is their vaccine. But it really was a joint effort, right? And now, as you said, Jaya, then, of course, Biopharma came to us and said, we also know how to make hepatitis B vaccine. And we also would like to have an indigenous vaccine because they've also been working with, the Chinese, I think, vaccines to kind of, again, reproduce somebody else's technology. They wanted to have their own technology. And I heard Bangladesh a lot during the call today. And we also are working with Incepta in Bangladesh. And now, of course, we are trying to find others that may be interested. Some of you may say, are we late? Why are we, would somebody even start doing this now? But the reality is, I think from the opening words, is we need buckets of much more vaccines, and we need vaccines that eventually can be the booster of choice, right? And that is cheap, that we don't have to spend, countries like Nepal that don't have to spend gazillion dollars to try to acquire vaccines, which are expensive because they're new technologies. There's no economies of scale, right? I mean, that's the reality. Even if they give them eventually something for free or semi-subsidized, they're costly because there's not an ecosystem of large-scale production yet, right? So I think, again, our role was this role of raising the importance of academia in the beyond just research role, but regulatory enabling activities that really open up the technology, offer the ability of help, offer the training, offer the fact that we want everything open in the public domain, that we value this concept of publishing, certainly the research and development piece. And that, we thought that, this concept of collaborating directly with those who we believe should own and have those technologies was the ideal process for us. And so we hope now that, if I close, that we now go back, that when we hopefully are out of this pandemic, that we resolve what we have and that we go back to sort of business as usual, maybe someone will realize that also developing a hookworm and schisto and Chagas vaccine is of great value. And then we hopefully can also advance the neglected disease vaccine ecosystem. Thank you, Jaya.
Well, that was fabulous, Dr. Botatsi, and I couldn't help thinking, the number of stories that you flagged up in the course of your talk, and one of the things is certainly about how journalists are really missing the true stories that they need to be flagging up, whether it's the success story of Bangladesh or all of these other developments that are happening in order to make therapeutics and vaccines much more accessible to the global south. I think these are the stories that need to be pursued and captured and better reported on, and also give a higher profile to those people who are sort of spearheading this whole effort in the global south. So I think it's a huge game changer, potentially a huge game changer, and it's going to be really interesting to follow the story as it unfolds over the year. I'm going to be a little greedy and take moderator privileges to come back to you with just one question before we move to the discussants, and that is, are you facing a kind of a pushback from Big Pharma?
I think we all have a position, right? A place. And I think they are, of course, they have their own business models, and, they have contributed, I have to say, thank God, at least they contributed, because we at least had those vaccines very quickly, right? I mean, imagine if those RNA vaccines wouldn't have worked. I think that was a little bit of a policy failure, at some level, because if you notice, the initial focus was we need speed and innovation, which of course is obvious that you need speed and innovation when you have an emergency. But if you invest just on things that are speedy and innovative, not knowing if they even are going to work, and totally neglect the things that are already out there, the ecosystem that it exists, I think that mistake was that they didn't balance that initial investment and decision of what portfolio would be invested. I mean, the US, only RNA and J&J were invested. Some others, maybe AstraZeneca and others, but then they kind of fell off the wagon, right? Or DNA vaccines and others. The CEPI network, all innovative technologies also. No one picked up a very simple recombinant protein, subunit type of, maybe except Novavax, but it's a little bit complicated particle technology, with simple adjuvants, with aluminum, things that are already out there that we knew they were going to be able to be scaled up in grandiose quantities in the event that we would actually need them, and not wait until now that we realized there was a global pandemic that we would never fill the gap. All of a sudden, oh shoot, we forgot about, these other technologies that are so relatively easy and scalable and robust, and we have, gobs of safety data, etc. Right? But at the same time, we at the back end, we were not that late either. Right now, we see that there's a need. But imagine if we had these before Delta, we probably wouldn't even have had Delta, right? And we certainly wouldn't have Omicron, right? So I think it's a little bit also of, not good policy, I have to say. And to the journalists maybe that are listening, it's amazing because, when our story really picked up, all of a sudden when they realized that, all of a sudden that our stuff didn't have any patent, right? We've always had, this notion that, our work was open, non-exclusive, that we were working with, developing country vaccine manufacturers. But the moment that all of a sudden, I think maybe even it was a little bit our fault. We should have said that from the beginning. All of a sudden, which is like, our technology was never patented. All of a sudden it went viral, right? But for the wrong reasons. It should have been picked up way before that, right? Of why we were not pushing more of these conventional platforms. And now everybody who has, these types of platforms, and we're not, of course, Bio is not the only one, or BioPharma is not the only one, there's many others that are advancing protein-based vaccines. We're found that now there's no more money, the pandemic's in a different situation, so we can't do the same type of clinical trials. We're faced with challenges in how to get approvals. And so, we're in a different stage, but, we are resilient and we will continue until we, of course, have enough to be able to close this equity gap.
Thank you so much. That was absolutely fascinating. And it also sort of underscored something that covering public health means not just a good understanding of science and being able to follow the science, having your contacts within research organizations and the academia and cultivating those contacts over a period of time so that you have a better, nuanced approach to understanding it and reporting on it. But also, I think we need a better understanding of business models for public health, how the economics of it all meshes with the science. And that's what this pandemic is really bringing home to us. Thank you so much, Dr. Kotatsi. I know we have audience questions and answers coming soon, but we'll have a quick round of comments from the discussants. Let me start with Ms. Lalita Kumaramangalam, who's the director of the India Foundation, for your comments and observations on what you've been hearing so far and what you think journalists need to focus on. Over to you.
Yeah, thank you, Jaya, for the opportunity to actually listen in to such fantastic and extremely respected voices. My take has always been that throughout the world, we have women who have always been at the lowest social, the last, right at the end of the social chain. And it is in every country, regardless of whether it is the United States or India or anywhere else, poor women, marginalized women who have the least and have access to any sort of medicines and healthcare. This is true of whether it's nutrition, whether it's polio shots for their children, etc. Now, for us to get to where we are in polio, eradicate it in India, it took 30 years. We can't afford to wait for even 3 years for COVID. As we know, it's mutating so fast. I just lost my extraordinarily beloved brother-in-law less than 10 days ago, less than a week ago, to COVID-related complications. I'm not somebody who comes from a background that does not have access to vaccines. He actually had his booster shot. And despite that, he passed away in 8 days. It's over so fast that it's only now that we realize that we don't even know what are the barriers that women face. It's not just about lack of access to internet or mobile phones. It's also about the fact that they don't even have access to information, basic information. We have been talking about the hesitancy, COVID vaccine hesitancy. These women don't know what it is. For them, vaccine is something like polio, which is for the children. Traditionally, historically, vaccines have been more for children than for adults. How many of our poor women anywhere in the world, Africa, Asia, anywhere else, know that there is an influenza vaccine that even adults take? So now the first step is just that. And like many other topics that were flagged, which have been, where many people have mentioned on this, in this forum, that journalists have not picked up on these things. Now, there's no point in constantly blaming either the state, whether it is the national government or the state governments. The fact is that journalists have access to baseline data that most others don't. And issues that should have been flagged, like just now, one of the persons whom I respect the most in the last, many months, Dr. Maria, said that journalists only started getting aware of the fact that theirs was a free vaccine, and after that started reporting, which is quite close. Just I think maybe a couple of months ago, I hadn't heard of her because I'm not one of the warriors for COVID, so to speak. But I can only tell you that even women who are in the army, where in the Indian Army, one of the Indian armed forces, said that because of when they're out on the borders, when they're not in the main cities, when they're not posted in the main cities, etc., vaccine, mind you, the army has got an excellent distribution system, etc., etc. They found that they were amongst the last to get it, even in the army hierarchy, just because of the sheer distance in the country. We are 1.37 billion and counting, if not 1.39 billion, I think, counting. And it's impossible for us to reach right down to the last person unless we use a distribution system that is already in place. I think Kerala did it very effectively, partly effectively, with the ASHA workers. Some parts in UP have done it, and maybe I'm told Jharkhand had some success in this. But the rest of India has not even thought about it. So in countries as large as ours, or where populations are large or densely populated countries, you need to have individual administrators who have done a good job. we need to also expose the fact that if one person, just one person, who has some authority in a particular place, takes the interest to actually see, that is, somebody said enlightened self-interest, because, well, ultimately self-interest. I don't know if I'm going to get infected by somebody. My poor brother-in-law, we still can't figure out how he managed to get the Delta variant of COVID. So this is not a virus that looks at, privilege, non-privilege, etc. And people in the villages, even in a state like mine, our state, Tamil Nadu, which is considered amongst best educated, best healthcare systems, etc. The number of people who don't understand that a vaccine is better to have at least one shot of the vaccine than to run away from it, is also due to the fact that so much criticism about taking the choice to take a vaccine. As if sometimes, a friend of mine told me, it's like telling somebody who doesn't really know the difference between different varieties of rice, that, this rice is better for your health and that is not. They just need to get the rice to eat. You need to fill your belly. So it's a rather maybe sound a little ridiculous, the anomaly of the whole thing. But the fact is that we must have journalists who stop looking at only what people want to hear. Everybody wants to hear good stories, happy stories, all of that. We need to start also telling people, we need to give facts. Every time I'm on one of these TV shows, it's not about facts, it's about opinions. Facts need to get out there. I know that everybody cannot analyze data the right way, but a lot of journalists, very, very reputed, very senior and very admirable work that has been done by journalists is not just getting reported enough. It's all become more about what can sell. And that should not be journalism. So let me say that women who can't read, for example, and a lot of women in India don't read, how much of it is actually also going into the vernacular? That's also my doubt. Perhaps not in our state of Tamil Nadu, but if you go to Jharkhand, Chhattisgarh, Bihar, many places, Jammu and Kashmir, for example, in the cold now everything is snowed under. Where are women having access to information, to data that will help them to make the right decision? All of us may say this is the right decision because we are informed, but they are not. Information doesn't go down to women in the grassroots. They may not always be underprivileged. In the villages, you may have families which have a lot of money, etc. But the women don't have information data because they have no financial autonomy or very little financial autonomy. They have to depend on others. Now, I don't know, we don't have, I think, engender data to that detail, especially in India. But these are things that at least the questions need to be flagged. So as somebody who's worked with women, I'd like to tell journalists to please ask some uncomfortable questions, not just to the politicians, of everybody. Whether it's the doctors in the big fancy hospitals, whether it is the bureaucrats who have power, whether it is any system, the justice, the police, all the people who have influence. Are they even looking at the last mile or last inch delivery, I'd say. Thank you.
Thank you so much, Ms. Kumar Mangalam, for those. I think that call that we should be asking questions of a whole lot of people, different kinds of questions to those in power. That will certainly be something that powers, I think, the journalists who are listening in, and we look forward to more stories of that sort. But I'm going to turn, before I go to Prithvi Shreedhar from Kathmandu, let me quickly go to my own stables here closer to home from the Hindu newspaper. I'm going to ask Jacob Koshi to sort of share a little bit of what your experience has been covering access to vaccines and equity issues. Jacob, over to you. If you're there, I don't see you on the screen. Yeah, you're
Can you hear me now?
Yes, Jacob. Yes.
Yeah, thanks, Jaya. So it's been a pleasure to actually listen to so many experts coming up with so many diverse views. And I thought that I would just, present some practitioner experiences, of actually having, being in a mainline general newspaper and covering it as a reporter. So I think while several points that you have raised regarding, many issues that have been insufficiently covered regarding access, equity, etc. But one thing that we also must realize is that one of the fields that actually got most badly impacted by the pandemic was journalism, was our profession. because there were several, in the first phase of the pandemic, this huge piece of information got out that, newspapers were actually carriers of the virus. So because of which, there were actually, papers being shut down, people didn't want them. And, ad flows, had an impact and actually led to several bureaus of mainline newspapers. I know several health journalists who actually were most needed at that time. They actually losing their jobs. And what really happened was that, you had this was the first, even seasoned health journalists who've been covering infectious disease, who've been covering a range of issues. Because of the nature of this, of this malaise that had actually struck the entire world, I believe, like the scientists, like the experts of the government, everybody was a bit off guard. People didn't really know what to expect. So the regular journalist who, was comfortable, talking to their sources in the health ministry or, to several other experts, is also at one time trying to understand what is this virus, what is this whole business of mutation, what is this, how is it affecting people's lives, usually with especially with constraints and staff cuts, etc. The average journalist was actually not only focusing on the health aspects, but also focusing on, on stuff like, how is, what are the consequences of lockdowns, mental health. Then there's a whole big issue of vaccines, equity, and, the variants coming in. And then there are conflicts between different arms within government of, who are genome sequencing. There have been scientists who've been warning of, new mutants coming. And how the entire information ecosystem of government really changed. Health actually used to be there used to be a time when health journalists and the scientists in the ICMR or other medical establishments had a kind of free flow of information, in sense, they could trust certain journalists with understanding health as well as scientific issues. But once this became the only news, like all things in India, this news became completely centralized. All information was then kind of walled, and people had to only such information as was approved, or government wanted to spin certain kinds of narratives, because in the first half of 2020, the whole issue became framed as a war that that India somehow has to win, and there became this whole issue of how does India compare to the rest of the world, when and the focus was on looking at, are we winning or are we losing? How are we doing vis-a-vis, compared to others? Secondly, another point that I'd like to bring is that, hypothetically, if this pandemic were to have happened before, let's say 2005, it would have been a very different sort of coverage, because that time we really didn't have this dominance of social media. There was the traditional channelization of public information has been through the print and the television media, and it's because the traditional media would actually had access to information first. In a sense, there was they had a lot more power to actually question government, to actually interrogate them. But because of this this phenomenon of social media, where government can actually directly reach out via these channels, there is a lot of data, there is a lot of information that is put out, but journalists too are then caught up. Because of the constraints because of the nature of a profession, many times journalists were caught up in the game of catch up. Here there is breaking news is no longer restricted to television, but it could just be on a website or on Twitter, and you spend a considerable amount of energy actually just trying to keep up with something like that. So, and this pace has been relentless. I don't see it actually easing out anytime soon. We're still looking at, we are constantly in reactive mode. There are fewer of us in general, and because of which there is there is limited in a sense, I would say, energy to focus in depth, in breadth over all the issues. But I'm very confident that over time many of these issues will be dealt with. Just as how the narrative on excess deaths, when a certain sect of people were covering excess deaths, were reporting that what the government figures is showing and what is actually being encountered by seen at crematoria or other places, there's a wide mismatch. I mean, we were actually, I know several people, and who were actually told that you should not be spreading panic, because this fear of spreading panic apparently was this big no-no. I mean, it was very hard for journalists, for editors, for people to consistently always draw the line between, do we go with the facts? Because again, that's also contested. I mean, what facts are facts? Are you sure that these facts will hold? Can we go, or will we be contributing to this whole aura of fear mongering? So this is something which which has always been I know for several journalists has been a kind of a difficult situation to actually negotiate with. Then there is also there's something what I call the unreliability of expertise. I mean, as journalists, we always would reach out to who we think were the experts. I mean, as health journalists, in pandemics, infectious disease, there are certain kinds of experts, who have got expertise in polio, whom we have dealt with before. But during the pandemic, we've actually seen that, some experts who would actually, in the early days, would advocate for something like herd immunity, over time, they would actually change positions. I mean, it actually became difficult sometimes that, okay, is this person still reliable? We've had this phenomena of several experts, cardiologists and, people with no expertise, particularly in public health, just wear white coats and, pontificate about everything about viral mutations and, say things like, children are going to be the next, victims of the pandemic, etc. And we know very well that these are people who are big names in the field of medicine, but do not really have expertise in this very specific area. So it's these battles that journalists consistently have to face. And finally, with vaccine issues and access, I mean, one thing regarding the production of vaccines, for instance, I mean, we saw how Bharat Biotech, in spite of having been given all green flags, I mean, they had very minimal standards of reporting results of trials, etc. They were really literally green flagged at every point. But the net result is that the number of vaccines that they've produced was practically useless as far as the larger vaccination drive of India is concerned.
I think it's actually 50 to 60 million a month is what they're saying now.
Yes, but they
much you can multiply the. I think if it's SII, it's something more in the range of about 250.
Yes, but they've never been able to actually meet their production capabilities, which is when you were actually exposed. I mean most Indians actually got to know about this thing that just because you commit to produce a certain number of vaccines doesn't mean they actually come up. And we may be good at making vaccines, but we're probably not as good as making vaccines extremely quickly. I mean, many of these production issues, I think we have the DBT has funded the Half-Kind Lab, several other government PSU labs, but where are they? Even Corbevax, it's only now that they have said that they probably will make about a few crore vaccines available to children and teenagers, etc. But again, we really can't rely on this. So there are these multiple issues that were going on, and I believe this was something that the challenge of the journalist.
Again, Jacob, a whole bunch of stories, in what you're saying, and I was particularly struck by what your observations about who's an expert and who do we. I mean, that's a major accountability issue, isn't it? Who do we hold accountable for, sweeping statements about this or that, giving out public health guidance that may not really be based on sound evidence. So we need to know who to go to, and I think that's a really important point which didn't come up. And thank you for flagging that. But I do know that we're running out of time, and I'm going to quickly move to Prithvi Shreedhar before I hand back to my colleague Sunny Krishnan. I know Ranjit is also, going to make some comments, but let me go to Prithvi, political reporter at the Kathmandu Post. Thank you for your patience, Prithvi. Over to you. You're muted.
Okay. It is the interaction has been very enriching and very encouraging, enriching for me. Even to have certain knowledge about the things we can report in the days to come. And while reporting, I'm not been doing the health story regularly, but during this pandemic, I've been also doing the stories about health. And what I have found in the context of Nepal, I just concentrate on the this vaccine issue. Initially, in January last year, Nepal started the vaccination, and at that time, the situation was that there were not many supply of vaccine, and uh, and at that time, Nepal heavily relied on India at that time in the initial days because Serum Institute was providing the vaccine at a very low price compared to other international vaccine manufacturer. Nepal had also was also talking with the Chinese manufacturer, and the official said at that time the prices they quoted was very high. So initially, Nepal relied heavily on Nepal. Nepal wanted the most of the vaccines would be supplied by India from India. So what happened at that time? That about and At that time also what happened is that there was some mismanagement from the Nepal government side, because there was I had also done reporting about it about the it's like corruption. It's like what happened. The company, the private sector company, that was quoting higher than what the Indian Serum Institute of India was offering directly to Nepal government. So at that time, there was certain influence from the private company, and that was quoting price higher than what the Nepal government paid initially to directly purchase from the company, and that problem that also delayed the Nepal, and that also delayed getting shipment from India in the initial days. So and even after paying paying for 2 million doses of vaccine to Serum Institute, Nepal could not get the vaccine in time. So what happened that after that India plunged into the crisis. This Yes, the second time this second time the COVID crisis. India plunged into crisis, and Nepal also fallen into crisis in the so in April in March India plunged into crisis, and Nepal also plunged into crisis in April. And at that time, Nepal failed to get vaccine from India until November, December. But Nepal at that time Nepal did not try to get vaccine from other sources like China and other Western countries. Initially there was a supply crisis. Nepal was not getting the vaccines, and it was very and at the same time problem of second wave arrived, and after the second wave ended, Nepal started to get the supply, and now Nepal is relatively in comfortable position in terms of vaccine supply. Nepal's population is 2.91 29.9 million Nepal's population, and there is a supply of over 400. Nepal's now the supply, there is a supply of 43 million. So there is almost double of the population. There is a supply, so supply is no problem. The problem now is in Nepal. What the problem now in Nepal is the providing access to all the people. There is obviously the supply, the vaccination rate is not far behind compared to other countries in South Asia, because it is 50%, 52% it's of the total population, and for the adult population it is 71%. So it's not far behind. But what's the problem in Nepal is that reaching out to the segregated and certain targeted certain population from informal sector. What I have observed from the informal sector, there are people from village to village coming to the urban areas and cities, and they don't have documents, necessary documents like the citizenship certificates, and it's necessary that you should present certain government document to be vaccinated. And they are also not probably there's no knowledge about information. There are information everywhere, but they may not have been properly informed about the availability of the vaccine.
I think this documentation seems to be a really key factor. I think some of the earlier speakers also flagged it up. Unless you have an Aadhaar card or a citizenship card or some kind of documentation, you're not able to access a vaccine. So forward, that's going to be an important issue for access to sort of address.
The government agencies also have not reached out to these people, because they sit in one place and they just wait for the people to come to take vaccine. That's why there's people who are daily wage workers. They have other priorities than getting vaccinated.
Absolutely. Yeah, thank you.
That's why. That's one. And another issue, just one point I just want to make is that another point is, it's in the villages there are people, many people have been migrated, young people have been migrated, and there are some children and older people. So they cannot travel to the place where vaccine is given. So they are also being denied the vaccination. These are the problem I've observed in Nepal in terms of vaccination.
These are great stories. These are again great stories, and I think many of these stories are not getting reported at all. Not just in Nepal, I think it's also true of India and some of the other South Asian countries, where those communities that are on the margins, access to vaccines for them has not been highlighted enough. In the mad rush to talk about national vaccine coverage percentages and so on, I think science stories are getting lost. So thank you so much, Prithvi, for flagging up those points. I'm going to go very quickly to Ranjit for your final comments, and then hand it to Sunny for any questions from the audience. Ranjit, over to you. I will try and be brief so that we can wrap this up quickly. I know we've overshot our time, so apologies to everyone who's still patiently tuned in and being a part of this conversation. So Ranjit, over to you for a couple of sentences, and then on to Sunny. Thanks.
Yeah. I'll be very brief. Actually, in fact, Jacob virtually covered everything. I mean, the whole gamut of. But there was, I just want to say, the attitude of governments. I mean, in India, it looked as if the government was doing everybody a big favor. I mean, that's the wrong signal to give, because it is in everybody's interest, and also the government's interest, to make sure that everybody's vaccinated and protected, and also stop the spread of I mean, that's the message they should have gone across. But then, it's as if, they are giving you, doing a great favor. I mean, that's terrible. I mean, you get the wrong signal. And also the other thing was the international aspect of it. I don't think a lot of that has really come out. For example, I mean, we mentioned Covivax. It is not very well known, but Covivax is the original Quad vaccine. In the sense that, the Quad countries got together and said that we have to compete with China, etc. And Covivax was the beneficiary. I mean, these are just two things that I thought I should mention. I mean, these are extra trends that people can actually report on.
Absolutely. I mean, thank you for bringing those points to our attention, Ranjit. Those were absolutely key. I'm going to quickly hand over to Sunny now for to take it on from here.
Thank you, Akka. Yeah, I think in the interest of time, I think we have just one pressing question here from the audience. And I think I'll field the question to Jacob. And if you could, I think it actually goes back to what what you were saying earlier. This is from Swagata. She said, we also need to acknowledge the fact that journalism has undergone so much change, which has affected coverage. Newspapers have cut back jobs and funding, and there's no space for independent journalism in India. We cannot expect world-class investigations when there are a handful of science journalists able to pursue stories in this way. What are your comments?
That's absolutely spot on, and in fact, one point that I didn't really raise was regarding the television media. I mean, there was a time, I mean, even it's what I said, even the time before social media became what it is, we had even the television media that was still seen as a kind of subset of journalism, as we knew it. But for a while, and especially that was amplified during this pandemic, despite the influence that television journalism has, the kind of reportage, the kind of, I mean, it never really did justice to the kind of influence that it could have had. And the reasons have been obvious for a long time. That's primarily because of the way the economics of television, works. I mean, prioritizing opinion, constrained to a 9 o'clock slot, rather than actually, hard reporting and generally drifting away from, topic to topic. So this absolutely is one of the, the ecosystem challenges. But yes, I'm still a little optimistic that, with the opening, I mean, social media also has thankfully translated into a lot of independent collectives of journalists, of reporters, who are coming up, and maybe independent newsletter-led initiatives, or just sometimes just pure Twitter-led initiatives, or different kinds of online communities, which I'm optimistic will find its own sources of funding and capital, and kind of recover some kind of lost ground. One thing that is positive is that people have realized that health journalism isn't something that you just give it to the third reporter after, who doesn't want to do politics or defense or one of those international security beats. It is it affects everybody's lives. I mean, that is one thing I believe the pandemic has brought to a larger global consciousness, and I believe that this will set in motion certain kinds of changes, and just hoping for the best, so to say.
Okay, thank you very much, Joshi. And before I pass over to my colleague, Dr. Jaya Shreedhar, and she did a really wonderful job. I'd like to take this opportunity to also thank the Sabin Vaccine Institute for kindly supporting this webinar. And also my heartfelt, gracious thanks to my colleagues in HQ, Pierre, Kathy, and also our global health advisor, Ida Joste. I think it's quite early for you and quite early for all you guys. And thank you for supporting us. Bear, especially from the Health Journalism Network. So all you journals out there, and if you want to join the Health Journalism Network, the link is over there in the chat. I know the power has gone off in Kathmandu, so I'll quickly pass over to my colleague, Dr. Jaya Shreedhar. Thank you so much to all the speakers and the discussants. You guys are stars, and thank you also to Dr. Maria Botalezzi for joining us in such an early time in Houston, Texas. Thank you very much. Jaya, to you.
Yeah, I join my colleague Sunny in thanking every one of you on behalf of Internews and the Accountability Lab Nepal and Sabin Institute for all your support. And I just wanted to say that, there was last week there was an op-ed in the BMJ where you had Dr. Catherine Otto Chebley saying that charity in isolation, I quote, charity in isolation doesn't solve inequity, it actually solidifies systems of injustice. And so we're so glad that in this webinar, we managed to flag up many, many issues from all of the brilliant speakers and panelists here. With the common thread, I think, that united all the discussions and all the interventions was that this is a call basically for greater self-reliance in the global south. And we're very grateful, Dr. Bodazzi, for sort of pushing us in that direction, and also for the brilliant advocacy of every one of the participants and the discussants for sort of keeping that, bringing that experience to this table. So thank you so much, everyone. And until the next webinar, stay safe and stay healthy.
Thank you.
Thank
Hi,
you.
thank you, everybody.
Bye.
See you soon.
Thank you, Jaya.
Thank you. Thank you so much.
Thank you, Jaya. It was a great, absolutely great experience. Thank you.
Bye.
Yeah, thank you so much, Ms. Kumar Mangala, for joining us. Absolute privilege to have you here.
No,
And
not at
Leena,
all.
such a
Thank you.
firebrand, and Dilrukshi and everyone, Patraleka. Thanks so much.